Okay.
Okay, well, we are live. We are live. I'm Bob Dietzel from KMRD, and I'm really excited to be here today. We're optimizing employer health plans. Wouldn't that be nice? When I was actually talking to Chris, I have Chris Van Buren and Dave Chase on the line. Chris Van Buren's at KMRD, runs our benefits group, and Dave Chase is with Health Rosetta, who is we're really happy to have Dave here from the West Coast to meet with us today. When I heard about the topics and heard about Chris's idea and the Health Rosetta model, I'm just really excited about finally a way to attack the healthcare issues from an outside of the box type of approach. So that's all I'll say. I'm going to hand it over to Chris Van Buren and have him do the introductions and backgrounds and take it from there. Chris?
Great. Thanks, Bob. Appreciate it. So I'm excited to talk with Dave for the next hour or so because I consider him to be one of the more influential authors and speakers in the healthcare space today. His organization, the Health Rosetta, has been the biggest influence on our practice over the past 5 years. Dave spent his first career in the technology space, working at Accenture, and then starting Microsoft's healthcare partner unit, which eventually grew to a $3 billion business. He was then with a few startups outside the healthcare space, and eventually came back to healthcare and co-founded Avado that was acquired by WebMD, which he left in 2015 and co-founded the Health Rosetta. He and the other co-founders of Health Rosetta have focused on healthcare fixes that are already out there and working. They analyze why they work and then find ways that those fixes can scale into the mainstream. Scaling up and out was a little easier in the technology space, but they found it definitely is possible here in the healthcare space. And that's the change that we, Health Rosetta, and the community of advisors that we're a part of, that's what we're trying to drive, even if doing it one employer at a time. So most benefit advisors, we often laugh that very few of us went to college to be in the employee benefits business. But here we are 10, 20, 30 years later, and we've made a profession of it. And here at KMRD, at the core, we love helping people, business owners, CFOs, HR professionals, the employees of our clients. We like helping them figure things out, solve problems. That's the common thread of why we're doing what we do. But it's, at times it's been tough to provide great answers. Sometimes it seems the best answer is finding the least bad option for clients, and that's frustrating when we want to make people's businesses better, employees' lives better. And, in our search for finding good answers, better solutions, we found the Health Rosetta Blueprint, which you see here on the screen. We'll touch on most of these core pieces in just a bit, but the key is we know there are fixes. We know we can find more money, create better employee experiences, and build better health plans. It takes more work, but it's so much more rewarding for us, for the clients, and most importantly for the employees. And now I kind of laugh. I think if more people knew what we're working on, what we can create, I think a lot more would actually go to college and purposefully choose to be a benefits advisor. So, Dave, some of what first caught my attention a few years ago is how you tied healthcare and its faults to problems outside of healthcare. I found that what you explained, I really found it important to understand the magnitude of what we're fighting. Each employer, each advisor, what we're all trying to fix. So whether it's government spend or what employers or individuals spend, the cost of healthcare is really taking away from a lot of important things. Do you mind spending just a few minutes talking about that before we kind of get into the rest?
Yeah, I mean, this is data from Massachusetts, and you could actually, zoom into an individual family and you'd see a similar dynamic where this looks at the spending in Massachusetts. I use it in part because in a lot of ways it's held out as a model for the country, and I tend to think of it more as a cautionary tale. And that if you look at the spending since the turn of the century, at the state budget level, which means state employee health plans and Medicaid. Of course, spending went up. Even in Massachusetts, you can only increase taxes so much. So what does it come out of? The things that have made the community really vulnerable coming in, certainly pre-COVID. I think of COVID as sort of a super spreader event on a set of pre-existing societal conditions that we've had. And so you look at the things that have hurt resilience at the individual level, at the community level, things like, what did it come out of? Education, mental health services, social services. I mean, mental health services, really core things. Broadly, they're referred to as the social determinants of health because they drive 80% of health outcomes, which is much more than the sick care system. And so it's really problematic. And then when you connect it into the kids in our community, if you look at the next slide, when I was out in Massachusetts almost 2 years ago, I was speaking and there were a few striking headlines. Two of them are here. During a robust economy, the Boston Public Schools students walked out basically for lack of funding. And at the same time, the Boston Globe reported that over half of Massachusetts schools had significant lead in their pipes. And you look at it, and it didn't end there. At the same time, there was a headline about how the Massachusetts hospitals had squirreled away $1.6 billion with a B in money in offshore accounts in the Cayman Islands. And that same week, the mega health system there announced another $1 billion medical tower. So we're literally poisoning our kids and damaging their future to fuel an edifice complex, and you'll see it. I mean, I've seen some headlines in Philadelphia, in your neck of the woods, more towers. No, there's no evidence that this is helping our health. They're essentially a tax on the American dream. And that's really the brutal reality of it. And from the standpoint of the working and middle class, it's not that employers have been stingy. Employers are spending a ton more money than they did 20 years ago. The problem is for the working and middle class, every dime of that and then some has been taken by a kind of a healthcare system run amok. So we'll talk a little bit more about that and what we can do about it.
Yeah, thanks. Like I said, that, as we've been getting to know Health Rosetta, and like I said, the influence over the last few years, the broader societal problem, but then also bringing it back to wages and what it's doing, understanding that problem, really ends up tying into like why we have to fight this and why we have to go to work and get going with it. So, more recently, you've brought to our attention the extracting nature of the healthcare system, how healthcare is, when you're experiencing it, most of it's a local experience, seeing your doctors, but the way the system is set up financially, it extracts a lot out of our communities. So, how does this affect the experience, our experience with the healthcare system, with it?
Yeah, I mean, what I say a lot of times is healthcare is not expensive. After all, clinicians are only getting 27 cents of every dollar that we spend. What's expensive is profiteering, price gouging, inappropriate treatment, administrative bloat, and outright fraud. And if you take a county like the one I live in, there's about 250,000 people. So if you look across all ages, we're spending about $2.5 billion. Very, very conservatively, at least $1 billion of that is extracted out of our local economy. And what's more local than interaction between a patient and doctor, right? I mean, people tend to think of shop local as a retail or food thing, and certainly is that. But again, what's more local than interaction with the doctor? And so it's pretty absurd that I tend to think of this as a tax by Wall Street that, we never voted on, because there's good people inside of the carriers and PBMs and mega health systems, but they're operating inside of a set of perverse incentives, and they're kind of operating rationally against that set of irrational objectives. So as we'll talk about, if you just remove the stuff that's actually not healthcare, it's not expensive. And that's how we can see the sort of results we're talking about.
Yeah. So what we're going to talk about today, it involves changing things. First, changing your mindset, and then eventually changing the mechanics of a health plan. But don't get us wrong. We don't take change lightly. We understand that a lot of people are afraid to make changes to their health plans because you're afraid that the change may be viewed negatively by employees. Because frankly, that's sort of what they've been trained to think over the last few decades. A lot of change to healthcare plans have been bad when they get made. And look, especially during COVID, we've heard a lot of employers say they want to make as few changes as possible because everyone's been through so much at work, personally, kids, with parents, all of it. And I don't know, maybe in 2020 was sort of needed, but we're thinking, coming into 21, it might be the exact right time to transform your health plan. People are accepting new normals in all phases of work and life, and especially in healthcare. Telehealth's gotten a lot of the attention, but even just using technology on simple things, making appointments, checking into healthcare appointments from your car, people are willing to make changes. And I think in the last few months, a lot faster than anyone thought they would. So we'd suggest, let's take this opportunity, use this time of change to get health plans to a better place. We're going to cover 5 areas, 5 steps employers can take, and employers don't have to take all of them at once, but there are 5 areas that can make big impacts on a health plan. I'm not going to read through each bullet point here, but because we're going to cover them, but you'll see highlighted at the beginning letter of each bullet spells out local. And as Dave was touching on, that's because we found most of the strategies that we're going to talk about work better when you dig into your local community of healthcare providers and build your health plan using independent local providers, and especially primary care doctors, and use them as the core of your plan. So let's get started with learning how to be liberated from the status quo. Dave, I touched in the beginning on people being afraid of change. So, what does it mean to leave the status quo, and what have you found is the biggest reason that management teams won't consider leaving a system that at best, the system's been challenging, and worst, it's been really expensive and frustrating?
Yeah, I can totally understand, as you alluded to, why somebody would be reluctant. What healthcare change has meant over the last 20 years is, great news, pay more, get less. That's been the story in healthcare. There's not a lot of trust there. The lowest net promoter score, which is a measure of customer satisfaction of any industry, lower than cable companies, airlines, are health insurance companies. So we haven't done a bang up job there. And most people tend to think fixing healthcare is like trying to fix Middle East peace. Like, they'd love that solved too, but it seems kind of hopeless and out of their control. And we really disabuse them of that notion. In fact, just a little sidebar that struck me as you were talking is, and you're bringing up COVID. The very first cases of COVID were in Kirkland, Washington, where I used to live. Their assistant city manager was one of these people who had that mindset shift. To their credit, the city of Kirkland, they did some of what we're talking about in this, particularly around primary care. The local hospital did some stuff with virtual primary care. And even though, it caught pretty much people by surprise, these are first cases in the US, you didn't see the sort of explosion in cases that you saw the other places. And a big part of that was having proper primary care and doing some things that we're going to talk about here. So I think it's worth mentioning. But again, let's speak a little bit to disruption. People are like, gosh, we don't want to disrupt the employees and so on. And I just it's funny, somebody introduced me as a disruptor recently, and I said, I take issue with that. I'm not a disruptor, I'm a restorer. I try to restore the American dream. What's disruptive is more than half of the American workforce is functionally uninsured. When your deductible and out of pocket is more than your life savings, you're basically a bad stub toe away from financial ruin. That's what most of our fellow citizens are going through, and particularly during COVID. And you know what else is disruptive? We're the undisputed world leaders in medical bill-driven bankruptcy. No country's even close. And 70% of those people had insurance. I don't know how you can call that insurance. And I'll tell you what else is disruptive. Our status quo health plans gave us the opioid crisis. What do who is impacted? Who still is impacted? Overwhelmingly working age people and their dependents. Who paid for that? Our employer plans. I'll just give you one example of how badly we deal with issues. Lower back pain. It's the second most common reason people go to the doctor. It's a number one driver of disability. It's the number one driver of opioid prescriptions. You know how much evidence there is that opioids work for lower back pain? Zero. Yet to this day, we still prescribe at 5 times the rate of other countries. So these are the type of things that as we go through, 4 of the 5 steps are either totally invisible to the member or only a clear positive. And so it's only the 5th one that you have to be really careful of. Again, we'll talk about it. You can do it right and it's a clear positive. But the other ones, they're really positive. And let's go through those.
Yeah, sure. So, the next topic, optimizing your plan infrastructure. This has everything to do with from the advisor you use to technology platforms to contracts with all the vendors involved. And as you mentioned, Dave, it's all behind the scenes. But it starts with, and a lot of it has to do with working with transparent advisors. And I like your perspective on this because you came from the outside of the entire employer health plan space when you got into this. And so can you give some background to this issue and what you've seen and why it's so important?
Yeah, I mean, I've been in healthcare, but health plans are almost like a completely different industry. And, if you want to get to the root cause of any issue, and the number of areas of dysfunction in healthcare are incredibly high. And every time I started asking why, and you ask why 5 times, you get to that root cause again. And it came back to the way we purchase healthcare, to be really candid, is brain dead. It's just been incredibly ineffective. And it's like, what's underpinning that? And so ultimately, this is kind of the master key that unlocks the doors to the high value plans. Most people, you talked about a box, most people are inside a box without the lights on and the doors are locked and the exits locked. This is the master key. Yeah, there's some savings here. Copper State is an example. They got $1,000 per employee per year of savings without changing anything about their network, PBM, any of that. But these are the things that we have shown here: the plan sponsor bill of rights, the advisor code of conduct, the advisor disclosure forms. You come from outside the industry, you're like, well, what's the news here? This seems pretty straightforward. Unfortunately, it's pretty much a polar opposite to the status quo. And so that's why, the tip of the spear of this movement is, working with advisors like Chris who honor the plan sponsor bill of rights and all that. So that's really the key. You can get some savings, but what it unlocks, that's critical.
Yep. So the next one, carving out PBM. Pharmacy benefits, I think, are perhaps the most mind-boggling aspect of our health system. So few people understand the layers and the players involved. I mean, when people explain it unfolds almost like a John Grisham novel. If you watched a movie about it and saw all the gaming of the system going on, you'd be like, no way. You'd chalk it up to one of Grisham's more outlandish premises, right? I mean, explaining how it works would take a whole other webinar. So we're going to avoid going through all the inner workings of what's behind a PBM and the pharmacy. But Dave, can you talk about what employers have done to improve their plan and make the prescription drug part of their plan better?
Yeah, definitely. This is an area where you don't have to change a formulary. You may have to change where people are getting their prescriptions. PBMs, pretty amazing. They've generated 32 different revenue streams. That's the last count. Most people think they get one or two. It's unbelievable, the opportunity. And if you look at a couple of the examples here of Caterpillar, really the only thing they've done is apply their supply chain expertise to pharmacy procurement, and they haven't seen overall healthcare spending go up in a decade, more than a decade actually. State of New Jersey, to their credit, when Governor Christie was in, the Democratic leaders, a union think tank, said, let's tackle this rather than having to cut services or raise taxes. They tackled healthcare. Just in pharmacy, in the first 3 years, they got $1 billion with a B, $1.6 billion of savings. So there's just tremendous opportunity. There are good PBMs, there are good approaches you can work out here, but it's one of the lowest hanging fruit areas you can imagine. And it can fuel and fund some of the next step even. So definitely is no reason to not jump in on this one.
Yeah. And so when we're saying carving out, I mean, a lot of the times the carriers, and sometimes you do need to be of a certain size, but the carriers, and merger and acquisition has happened over the last year. The carriers bring their own PBM, and it's very often not very transparent as to where those 32 different revenues of stream are going. And so they each own or are tightly aligned to their own PBM. And so the carving out part is actually trying to go to an independent, more transparent PBM, if at all possible. So, onto primary care, while I think pharmacy and PBM is one of the more mind-boggling aspects, in contrast, I think the topic of primary care is sort of the opposite. Once it's brought to your attention, it's so strikingly simple. It's so simple, but barely recognized because of the way health plans have de-emphasized and devalued primary care over the last few decades. And so while it's very basic, it's also not necessarily easy to change it all at once across the whole system. But some employers have changed it, and with really good success. Dave, can you tell a little bit about what you've seen at employers, around the country and what they've done in this area?
Yeah, it's pretty amazing. I mean, to begin with, there is no well-functioning healthcare system in the world not built on top of proper primary care. We've unfortunately destroyed primary care over the last 20, 30 years. It's getting rebuilt kind of brick by brick. And so you see some of the examples here, some of the biggest long-term examples like Rosen Hotels. They've been doing this for 25 years. They're spending 55% less per capita overall on healthcare. Guess what? Even if you have price gouging hospitals in your neck of the woods, it's impossible to price gouge on an ER visit that never happened. It's impossible to price gouge on a surgery that never happened. And those can typically get reduced 50% when you have proper primary care. And proper primary care, when it's fully actualized, again, you can step into this over time. It includes things like physical therapy and mental health services and social work and things like that really do make a big difference. And, like Rosen Hotels, my last book before the Relocalizing Health was on the opioid crisis, looked at the healthcare system through the prism of the opioid crisis. And I went back and asked them, gosh, what's your issue with opioids? workforce, they're a hotel company, physically demanding. You would think they would have a lot of back issues and stuff like that, a lot of maintenance workers. And they're like, well, I don't know. We'll go take a look. Well, guess what? They had prescriptions at 1/6 of the level of a typical American employer. So they really don't have any opioid problem to speak of. And these type of things, it's really amazing. And turns out when you have full primary care, fully 90% of the issues people come into the healthcare system for can be fully addressed in that scenario. And frankly, most of the time, it doesn't require a face-to-face visit. That's been particularly important during COVID. In fact, we've seen this kind of terrible dichotomy where on the positive side, the folks who've been doing this didn't skip a beat. They didn't worry about in-person visits. Only the people that really had symptoms, needed to come in for test or some other health condition independent of COVID could do that, didn't skip a beat. At the same time, normal primary care that's been in this fee-for-service model, they're closing their doors. At the time when we most need them, there's huge numbers that are closing their practices because they were dependent on this sort of hamster wheel fee-for-service model. And at the same time, I got to note, guess who's had the best earnings reports in history? The carriers. Like, how backwards is that? That carriers are having, like, the pandemic is the best thing that ever happened to them financially. And yet we've got independent practices closing their doors. And so this is the type of thing, like, we really have to look at ourselves in the mirror and say, okay, yeah, we have different challenges. We have distributed workforce. Our health plan, we're just a 7-person company. It's built on proper primary care, but there's not direct primary care where I live. I have virtual primary care. Other people have direct primary care. If you're a bigger employer, you could have an on-site, near-site clinic like the city of Kirkland has. So yeah, it's really important, incredibly valuable when it's done right.
Yeah, and I think your point there at the end is it can come in lots of shapes and sizes. Obviously some larger companies, 5,000 employees, all in one place, they might build an on-site clinic, and that'll provide a lot of it. But in the last, I don't know if you'd say last decade or definitely the last 5 years, a lot of other types of services have come around, whether it's local direct primary care, physicians, or virtual primary care. It can come in, and it doesn't need to be that intimidating. These employers, a 200 employee employer doesn't have to go build an on-site clinic. There's things that have been, the infrastructure is getting built out a little bit better that they can tap into, right? I mean, you guys are, I know I've heard you go through it, but you're about a 10-person organization with employees, and you guys have based your plan on a form of primary care, right?
Yeah, I mean, we felt like we had to walk the talk, right? If we're out there pontificating about this, we need to. But no question, it's harder when we only have 7 people on the plan, so it's harder, but you can still do it. There's definitely a way to do it, and again, starts with primary care, and it's you talked about the build out. City of Kirkland, they use one of these on-site, near-site clinic providers, and so that happens to be based in Seattle as well. And so you have like the city of Kirkland, the city of Everett, these are 2 suburbs of Seattle, Trident Seafoods, Expedia, Seattle Children's Hospital, their employees, Virginia Mason Hospital, their employees, they all get their primary care through them. And so they're distributed around Seattle. So, and they're all open to each other's employees. So maybe you work in Seattle, but you live in Kirkland, you can go to the Kirkland clinic. And so that's kind of the way that you see these things get rebuilt brick by brick. Sometimes people, unfortunately, they kind of have this tyranny of low expectations that we can't fix healthcare and it's impossible. Oh my God, primary care is not there. It's like, yeah, it took us 20 years to destroy primary care. It's not going to get rebuilt in 20 days, but it's not that hard either. And particularly, we see a concentration of activity geographically, and then you sort of get exponential returns as more and more employers are doing this type of thing.
Yeah, and it's pretty cool. my daughter sees one. I don't think I'm breaking HIPAA here, but my daughter goes to one. And in addition, I mean, it's great. She keeps her, going off to college and that type of thing. But also, we've met with this person, both from a business aspect, taking a look at them as a vendor for plans, but they're so refreshed. The ones who have made the switch. So this is all we've been talking about: employer plans and the member experience. But the doctor themselves, when they've made these switches, they are so much more refreshed. They're not going through 7-minute appointments, 35 of them a day. It's just a way better way for them to practice too.
A lot of people they just think that, doctors are privileged class and they're all fine and good. There's record levels of burnout and even suicide right now amongst clinicians. And actually it's gotten worse during COVID, but it existed before COVID. So, I mean, in many ways, they're more of a victim of this than we are because they live it every day. So it is, I mean, one of the funnest parts about my job is kind of liberating people from, they might be working in some mega health system or, whatever, and they sort of rediscover their calling. These are people who, while we were having a good time in college, they had their nose in the books and were studying away, and, most of them didn't really start making any money well into their 30s. Yeah. So, I mean, these are incredible people, the nurses, the docs, and all that. That's not the issue. We just need to get them in the right setting.
Yep. Yeah. So the next topic, the last one that you had mentioned earlier, that, is one of the tougher ones, and it's out there affecting the employees, and it's something that I think a lot of people at first blush they don't get it, because after almost 4 decades of the big carrier networks being a staple of health plans, it just doesn't even register. We discussed changing the PBM, and once explained, I think most people are like, heck yeah, let's do it. And primary care, once explained, I find a lot of people say, wow, yeah, makes total sense. It might be a little difficult to implement this, but let's work on it. Let's get there. When talking about the big carriers networks, even after explaining it a little bit, I think people are so programmed on using the biggest network, having all doctors in the network, that leaving that is unbelievable, like literally not believable. So, even if you show numbers, provide proof, it's tough. I think this one really goes back to our first topic of leaving the status quo. It's something that really takes a while to grab onto. So, can you kind of walk through how this, actually often adds to a plan? It doesn't take away from a plan. If you're
Yeah, definitely. This is the biggest reward in all of this, because there's so much price gouging, and again, we came in with fresh set of eyes. I thought sort of the same things that most people think. You think, and a lot of times you ask people, oh, where do you get your health care? They say, oh, Blue Cross. It'd be like saying, what car do you drive? Geico. It's like, what? Like, the care is actually not expensive. Unfortunately, what PPO networks have become is just a tremendous value extraction device. I mean, I wrote the most read article I've written on Forbes was, have PPOs perpetrated the greatest heist on the American citizen? Spoiler alert, yes. And so what you do here is actually straightforward. Pacific Steel. This is a 750 person manufacturer based in Montana, 9 states, 40 locations, and they did not like getting price gouged. And oftentimes it's the same docs, just different facility, different means of contracting. Their spending 4 years ago was over $8 million. Last year, they closed out at under $3.5 million. About 3/4 of that was this. How did they do that? They just put in really simple contracts, 5,000 contracts in 2 years. You don't have 5,000 contracts in 2 years just being a relatively, they're not like Walmart or some mega employer, unless these are incredibly simple, fair agreements. And so here's what the average member understands: zero. Like, do they understand EOBs? Can they decipher a hospital bill? If you've had anything of moderate medical complexity, by design, these things are just a complete nightmare. You can't decode them by design. And here you say, if you go here, you consult with us, it's non-emergent, Bob's got a rotator cuff procedure. Okay, we call the hospital up. If it's not one we've worked with before, and say, hey, Bob needs a rotator cuff procedure. We'd like to pay you. We do prompt payment, so you don't have to chase after, some carrier for a couple months. We waive all cost sharing for the member. That's the zero part. So you go to the member. If you go here, the only paperwork you got to deal with is a thank you survey afterwards. We're going to waive all the cost sharing. They get that. And the providers love it. Usually we're actually, with the independent providers, we're actually increasing what we pay them, and we pay them within a week. And I mean, it's a little jarring for them at first, but once they go, okay, wow, that sounds great. We love it. And sort of like the professional, what we were talking about on kind of the burnout the docs face, guess what's the biggest driver of burnout? It's dealing with insurance bureaucracy. And so you remove that pain from them, and you give them a good set of, well-paying patients. They love it. And here's the sort of punchline in this story. I talked to the CFO of Pacific Steel and said, okay, you're a mature, slow growth, low margin manufacturer. What would you have had to increase top line sales to have had the same EBITDA impact, your profit impact? So we would have to increase top line sales 25 to 30%. How many mature manufacturers increasing 25 to 30%? They happen to be an employee stock owned company. And so basically the nest eggs got doubled for the workforce. They had a forklift driver recently retired after 30 years. I think he topped out at $45K a year. I can't disclose the exact payout, but it was well into seven figures. How many working class people are retiring with seven-figure nest eggs? That wasn't entirely healthcare, but it was probably half healthcare. That's what's possible. That's the kind of reward. So yeah, you got to be very thoughtful. You got to do it right. At our last summit, you may recall, Chris, in-person summit, we had one of the other Health Rosetta advisors go through a member education. We just kind of took them through the basics. And you had people shift from, they were ready to pull out their pitchforks, if we were going to change stuff, to like, they were ready to go after the, with the pitchforks, the health systems, the PBMs, because like, oh my God, that's where 20 years of wage gains have gone. So a little bit of education goes a long ways, and then having the right contract. And so, yeah, you definitely got to be thoughtful on this one. Most people aren't going to rip off the Band-Aid right away and do it. Some do. We had Megan Narance has got a manufacturing client, about 60 employees in rural Washington, basically where grunge music started, Kurt Cobain, in a pretty depressed area. And the reason they ripped off the Band-Aid right away, they got a 55% rate increase from the big carrier. And they're like, this is going to crush us. It's going to crush our members like hell. And that was on the back of prior 2 years have been 20% increases. So they did it all what we're talking about. Guess what? A 60-person company, they decreased their spending that following year. Rather than that 55% increase, they decreased their spending $600,000. Like, they're very happy. And their members ultimately understood why they were doing it. So it's definitely possible. You got to be smart about it. And that's why you work with somebody like Chris for it.
Yeah. And we've learned through some of that too by going through it with the education. We have a local client, about 300 employees, and when presented with sort of phasing in or ripping off the Band-Aid, as you said, they said, hey, if we're going to make a change, let's make a big change. And they saved about 30% in the first year from what they were doing with the carrier. And, we got the message through to some employees, but not all. And so we've learned our lesson that if they don't, like with this network, most people out there assume from the last 40 years that, like, yeah, when you have one of these big carriers, and not to pick on any of them, Blue Cross, Aetna, Cigna, any of them, when you have one of those big carriers on your card, you've assumed that the biggest negotiating power has come to your rescue and has negotiated the best deals across hospitals and everything. And the education that, hey, we're fighting a battle to do better than what they've done, because, without getting into the details, it's just difficult to educate them, but it has to be done thoughtfully, like you said, that there's this greater thing that we're trying to do.
Yeah, and just real quick, I go into this in the book, but there's good people inside of those carriers. I said they have perverse incentives. The thing that trumps everything is they have a shareholder fiduciary duty to facilitate price gouging. That is their legal duty. And that's a function of, to get wonky, the medical loss ratio that came out 10 years ago. And so they're operating rationally, but that doesn't mean you have to operate in that irrational world. And there is another way around that.
Yeah. So as we had mentioned, we touched on five things, 5 steps. They never have to be done all at once. Some people take, they crawl before they walk, and then they walk before they run. Some people go from a crawl to a run, but there's various ways to do it. We know that each of these, even on their own, can help a health plan. So with that, Bob, I don't know if there's any questions or.
Yeah, we have a couple. One is, do I have to be self-funded or self-insured to do these strategies?
Yeah. So, the answer is you're going to have the most flexibility, and we're going to be able to dive into these things the best when you are self-funded. We're going to have the most flexibility. Carving out the PBM is going to be definitely the easiest if people are self-funded. But with people who are smaller, people who can't take that risk yet, or if the employers are under 100 or under 50, there are still steps people can take. They can definitely they can put in primary care and do that with fully insured plans. Dave, I don't know what your comments are on. I mean, you can get started to some degrees, right?
Yeah. I mean, as we talked about briefly earlier, we're just seven people on the plan. So we sort of mimic being self-funded in that we, effectively self-insure for the claims from $1,000 to $6,500. That's not going to ruin our self-funded bootstrap, organization. And then above that, the equivalent of stop loss is our very high deductible, plan. And we've only had 1 year where we've actually had any claims go into that realm. So I'm glad we had it. We have an MS case. We definitely would like it for that. But first and foremost, we started with primary care and then built from there.
Yeah.
I have 2 other questions, but they're somewhat interrelated, I think. Question is, what if I already renewed my plan? How do I change the process now? What's the best first step to get started?
I'd actually say it's almost best starting this conversation right after you renew. I don't think inside of the 90-day, the sort of typical 90-day or 120-day, I think starting this to do sort of a plan opportunity assessment about where things are, what the appetite for change management is a big part of this at a company, and how strong is the management team in terms of when change comes about, are they able to implement change? And so how much appetite do they have to change at the administrative level, some of the behind the scenes things? And then how much appetite for change do they have for the employees to experience a change? So to me, and with a lot of our current clients, we begin these discussions a year out, 10 months out, that type of thing. Dave, I don't know if you had any thoughts on that.
Yeah, definitely. I'd just echo a couple things. One is, we're all familiar with second opinions, for cancer cases or something like that. It's always good to get a second opinion on your health plan. And one of the things that we team up with advisors like Chris on what we call plan opportunity summaries, where we can kind of do a high level assessment, and then we can dive deeper if you want, where you get into some of the kind of diagnostic questions of, what is the appetite for change? And, you're not going to probably do change in every possible area. And, do you want to do it behind the scenes? Do you want to do it with members? What risk appetite do you have? And that's really important. But, I always get asked, where do I start? Right? I get asked that all the time, having come up with this blueprint. And I always say, you got to get the right advisor, benefits advisor. If you don't have the right benefits advisor, the typical folks, again, they're not bad people. They're just, their box of solutions are really confined. And that's the nice thing, is you can get out of that box and then really tailor things to the particular organization based on the needs of their workforce, the culture of the organization, and then start stepping through it. You might do it over 2 years, 3 years. That all, depends on the organization. But you want to be thoughtful on it. And one nice thing about the fully insured plans or the carrier plans is, if you wanted to cancel it next month, you can. You just stop paying premiums. It's not like a typical contract. The nature of these is you can change at any time. That's not saying that's what you want to do it that quick, but there is that flexibility, because you can do things mid-cycle. Sometimes we'll see that they'll just go from the same carrier who is offering that kind of fully insured plan to working in their, they'll still do claims and stuff like that. You're not going to get all the benefits, but you start getting access to data and things like that. So there's a variety of strategies that can be quite effective in making that transition.
Yeah.
Oh. Well, I guess, thank you.
Yeah.
There aren't any other questions. So if you want to close, Chris, go right ahead.
Yeah, sure. So some contact information here, and Dave's latest book. Well, the first book, the CEO's Guide to Restoring the American Dream. That was a few years ago, and I loved reading that book. Really changed a lot of how we think about things. The latest one, Relocalizing Health, builds upon a lot of the same core foundational points of the first book, but really brings out a lot of the local part of healthcare. So available for download at the web link there. But outside of that, Dave, really enjoyed it. Thanks for your time. Much appreciated. And
well, thanks for the great work you guys are doing out there.
Yeah, great.
Thank you.
Thanks.
Thanks.